Probably second in the amount of excitement to documentation is billing. And, I've definitely worked in clinics where we just wrote down what we did and somebody else did the billing. Maybe we wrote down the units of what we did. But more and more, particularly with electronic documentation, and they're sort of trying to cut out that person who does the billing, unfortunately, for people who are medical billers. The therapist or the healthcare provider is doing the billing, or they're documenting the billing. So we have to know CPT codes and billing units. So the learning objectives for this little module, there are 23 slides, but I'm not going to spend a ton of time on each slide, but it's there for you just in case. You want to be able to report the appropriate CPT code for each PT intervention you learn. So everything we learn in school, there's a CPT code for it. Maybe not just one. I'll talk a little bit about the variation in billing. And you want to be able to accurately record the billing units for each treatment session. So CPT codes are published by the American Medical Association. And throughout the whole set of them, there's only a certain part that applies to PT and OT. They use terms, they say physician, qualified healthcare professional, individual, and that means you. So sometimes they'll say the provider. That means you. You're the provider of the service. So it doesn't mean that people other than physicians can't report the service. It just means that when they say physician or qualified healthcare professional, that means you, the healthcare provider. So the most common CPT codes used in physical therapy are in the range from 97110 to 97140. Therapeutic procedures, that's that range of codes are called therapeutic procedures. And by that, the AMA defines therapeutic procedures of a manner of effecting change through the application of clinical skills or services that attempt to improve function. Isn't that a nice little nutshell of what we really do? So the physician or other qualified healthcare professional, i.e. the therapist, is required to have direct one-on-one patient contact for all of these codes except for group therapy. Group therapy requires that you're constantly in attendance of the group, but you are not required to have direct one-on-one patient. And so group therapy is something that we haven't talked about much in school, and you won't see it in every setting that you go into. But it's getting to be sort of more popular, I guess, if you want to say that, in different settings. And the setting where I work, for the last 10 years, we've had a joint replacement group that's been very successful for the clinic and for the patients. And so I'll just talk a little bit about group therapy and what it entails. So direct one-on-one contact is what these codes imply. So the most commonly used codes in PT, I'll list them all and talk about them, are 97110. That is the most commonly used CPT code in PT. Therapeutic procedure, one or more areas, each 15 minutes. Therapeutic exercises to develop strength, endurance, range of motion, and flexibility. Endurance is in bold there because I wanted to point out something about that. If you are doing therapeutic exercise for endurance alone, that may not be reimbursed by different insurance companies. And it's up to the insurance companies to decide what they want to reimburse. So you can include endurance as part of why you did it, especially if you say, well, the person needs to be able to walk 250 feet to get to their dining room in their assisted living facility. It's really relevant to work on their endurance to be able to do that. But just know that you're not going to be billing for endurance training alone. 97112, they all start with this: therapeutic procedure, one or more areas, each 15 minutes. Neuromuscular re-education of movement, balance, coordination, kinesthetic sense, posture, and or proprioception for sitting and or standing activities. So this can include, and note the word re-education. You're retraining a movement that they have lost either because of an injury or because of CVA or something else. So we're re-educating their neuromuscular system. So any balance activities you work on, BAPS board is a neuromuscular re-education. Having them stand on the trampoline while you throw them a ball, re-educating proprioception and kinesthetic sense. Balancing on a Swiss ball, using the body blade, PNF, NDT, a lot of the things that you learn in your neuro rehab class. 97112. That is a lot of times when I'm working with even someone with an orthopedic injury, we usually have 45 minutes, which is 3 units. And I usually have 2 units of therapeutic exercise and 1 of neuromuscular re-education because I'm working on balance, coordination, proprioception, that sort of thing. So those 2 very common codes. 97113, therapeutic procedure, 1 or more areas, each 15 minutes, aquatic therapy with therapeutic exercise. So it doesn't matter what you're doing, if you're doing neuromuscular re-ed or therapeutic exercise or gait training, if they're in the pool, it's aquatic therapy. So if you, a lot of clinics either have pools on site or they do aquatic therapy at another site. The reason they do it is because it's awesome. We have a pool on site, and aquatic therapy is fantastic. But if you even, it doesn't matter what you're doing in the pool, if they're in the pool, you charge 97113. 97116, therapeutic procedure, 1 or more areas, each 15 minutes, blah, blah, blah. Gait training includes stair climbing. So if you charge 97116, you should, in your note, in your objective systems, you should have comments about gait cadence, whether their steps are equal, their stability when they're walking, what kind of assistive device they're using, if any, how they get up and down the stairs. Do they do it with 1 rail? Do they do it with 2 rails? So you should have gait-specific documentation if you're using this code. 97124, therapeutic procedure, 1 or more areas, each 15 minutes, massage, including effleurage, petrissage, and or tapotement, stroking, compression, percussion. So this is not like a massage where you're on the beach in a cabana getting a massage. This is using specific massage strokes in the course of a PT treatment. Up until 2018, Medicare Part B was not reimbursing for this code, and we used 97140, manual therapy, which is the next one. But since 2018, they actually do reimburse for that. You have to say why you did it, like you're doing it to increase circulation to promote healing. You're doing it to decrease swelling. But that is something you definitely want to check with your clinic, whether or not they are billing that code, because some insurances will reimburse, some will not. And that is something that your clinic can guide you on, whether or not they're using that code. 97140, on the other hand, manual therapy techniques, they're mobilization or manipulation, manual lymphatic drainage, manual traction, 1 or more regions each 15 minutes. So this includes soft tissue mobilization, myofascial release, serial compression bandaging is billed under manual therapy, joint mobilizations. So a lot of the hands-on things that we do are billed under 97140. Group therapy, it's a therapeutic procedure with a group of 2 or more individuals. If you have 1 person, you can't bill group therapy because it's not a group. Group therapy procedures involve constant attendance of the physician or other qualified healthcare professional, that's the AMA's wording, i.e. the therapist, but by definition they don't require one-on-one patient contact by the same therapist, and it's untimed. So you only ever charge 1 unit of group therapy. The other codes that we just talked about are all timed. It's 15 minutes. So you see in the definition of them, 15 minutes, 15 minutes, 15 minutes. So 1 unit of that is 15 minutes. 1 unit of group therapy code is any amount of time that you spend with a group of 2 or more people. Okay? So therapy, sort of what it is and what it isn't. It's not what the patients are doing that determines whether it's group therapy. It's what the therapist or PTA is doing with the patients. How are they treating the patients? Is the PT or PTA one-on-one with one patient while the other patient is doing an intervention independently or under supervision? Or are they in constant attendance of both patients providing a skilled intervention with no measurable amount of direct one-on-one time spent with either patient? So I'm going to give you examples of both of those. So if the therapist or assistant is in constant attendance of 2 or more patients providing skilled therapy, but not providing any significant amount of measurable one-on-one time to either patient, either in land or in an aquatic setting, that is group therapy, and it's billed 1 unit of 97150. It's a service-based rather than a time-based. Okay, so it doesn't matter if they're there for an hour and a half, you bill 1 unit of group therapy. So the example that I'm going to give is you have 3 patients in the gym for a therapeutic group program. The first one, you get a patient started on an exercise, you get all 3 started on exercises, and then you check in with them, correct maybe their form a little bit, make sure they're doing things correctly. You're providing skilled therapy by correcting their form. So having a non-licensed person like an athletic trainer or a exercise specialist or something in charge of a group of people exercising is not considered group therapy. You have to have a therapist or assistant in there working with the people. So sometimes, like when I'm in group, I have 2 people that are starting. They both have the same diagnosis. They're going to be a little different, of course, but I'll start them on the same thing together. I'm like, okay, you guys are going to do this. I instruct them how to do it. I check in on the 3rd person, get them started on an exercise. I come back to the 2 that I instruct in that exercise and see how they're doing. They're doing great, except this one person needs a little bit of adjustment. So I adjust them, I go back to the 3rd person. So it's very multitasking, group therapy. If instead I got people started and then I spent 10 minutes of one-on-one time with one of those people working on their exercise or doing some manual treatment or something like that, you cannot be doing group therapy and one-on-one therapy at the same time. You're doing one or the other. So in the time that I'm doing that one-on-one therapy, if it's really truly one-on-one, I'm not paying attention to those 2 other people, and so I can't charge them for group therapy for that time because I'm not actually doing group therapy. I'm doing one-on-one with the other person. So there's a difference between dovetailing, having 2 people that you're performing one-on-one treatments with at the same time, versus group therapy. So just make sure if you have a group therapy setting that you know how to do group and what you're doing. So Therapeutic Activities 97530, it's direct one-on-one patient contact, the use of dynamic activities to improve functional performance. So lifting, carrying, pushing, pulling, pinching, grasping, crawling, climbing, lunging, throwing, catching, jumping, car transfers, overhead activities, simulation of functional activities. One time, years ago, I worked with this young woman who was in school to become a hairstylist, and she had been in a car accident, and her neck and shoulder were affected in the car accident. Well, she was doing pretty well. She was improving a lot, but she had a hard time holding up the hair dryer over someone's head for as long as she needed to. So we did an exercise where we had a TheraBand for resistance, and she was doing like a hair drying motion with her arm. This is a great example of simulation of a functional activity. So I think I billed it under therapeutic exercise, but I probably should have billed it under therapeutic activities. It may also include bed mobility and transfer training. So anything that person needs to learn to improve their functional performance. It also involves the use of functional activities to restore functional performance in a progressive manner. In other words, say that you're practicing sideline supine to side lying to sitting, supine to side lying to sitting. And what you're trying to do is you're trying to improve their bed mobility. You're trying to make it so they can get out of bed by themselves. So in the next visit, maybe you're working on supine to side lying to sitting, and then a sit to stand. So we're starting to transition into transfer training. That's our progressive manner. So therapeutic activities is an important CPT code that we often do in the clinic, and we need to bill it as such. So self-care / home management training, a lot of times you're dealing with activities of daily living, compensatory training, safety procedures, instruction and use of adaptive equipment for 15 minutes. A lot of these you'll see are sort of OT related, like bathing, grooming, dressing, personal hygiene, basic household chores, cooking, using appliances, medication management. An OT is often going to be addressing these a lot more than we are. However, you might be working on, say you work in a skilled nursing facility and you're working with the PT or with the OT on an individual patient, you're doing multidisciplinary treatment, and the OT says, well, they would be able to dress if they had more range of motion in their shoulder. Well, when you're in your PT session, you're going to work on range of motion in their shoulder, and the OT is going to work on dressing. So the one thing in the clinic where I work, where we bill self-care home management training a lot, is safety procedures, instruction and use of adaptive equipment, and pain management techniques. Because we have a chronic pain education program, we probably bill this code a little more than most PT clinics do. So it's there, but you're not going to use it for all home instruction. When you're instructing a patient in their home exercise program, use the code that best describes the focus of home activity. So if you're instructing a patient in balance or coordination activities to do at home, use 97112, neuro rehab. If you're instructing the patient to do exercises at home that are going to improve range of motion or strength, use 97110. If you're instructing the patient using a sock aid for dressing, then you can use 97535, because that's a self-care activity. So it's a little nuance to it. Wheelchair management is, unless you work in a clinic or setting that specifically does this, you may not use this code. It includes wheelchair evaluation performed by a PT or OT. Of course, we're not going to be doing that. But it also includes testing the patient's ability with various chair functions. Say someone just got a new chair and you're teaching them how to use all the adjustments. It also includes determining the type of seat, cushion, back support, head and neck support, armrest, leg rest, brake extensions, anti-tip bars, etc. Or training the patient and family in the use of the wheelchair. So that's really the training the patient or testing their ability with various chair functions. Maybe you're teaching them how to drive their power chair. It's not as easy as it looks, I'll just tell you that. So we might use this code in certain settings. So CPT code 97750 is physical performance test or measurement with a written report. So timed up and go, Tonetti, balance test, dynamic gait index, all those things listed there. The 15 minutes includes the time required to analyze and interpret the resulting data when the patient is present. And it's you need a separate and distinctly identifiable signed written report when you're billing 97750. So this is often done in an evaluation or a reevaluation. We don't use it very often as PTAs, but there are times when you might be spending a lot of time doing this retesting because you're directed by the PT to do this, and you're doing that written report. You might use this code on a rare occasion. I can't even tell you if I've ever used this code. I don't remember ever using it. But it's intended to focus on patient performance of a specific activity or group of activities. So those tests that result in a written report. 97763 is orthotic and prosthetic management or training. It's a 15-minute code again. A lot of times I'm working with modification of prosthetic fit using socks or socket liners, mobility training, skin care, overall conditioning. As soon as they start gait training with the prosthesis, then you report it as 97116, gait training. But if you're doing prosthetic care and prosthetic training and working on prosthetic fit, then you can bill 97763. And again, you might not see this in every setting. So here's our list of commonly used CPT codes that I've gone over. By and large, these are going to be the ones that you use on a day-to-day basis, particularly 97110, 112, 116, 140, and the Therapeutic Activities code, which isn't on this list. But anyway, so those are the main ones you're going to be using. If you do specific modalities, you'll use a specific modality code. Some of them are timed, some of them are untimed. I kind of clumped the untimed ones up in the corner there. But you'll find that you get to know 97110, 112, 116, and 140 really well. That is largely what we're going to be doing. So billing is not a science, it's an art. A lot of physical therapy practices get underpaid because they use the wrong code. As a PTA, you should really depend on your manager or your clinic to guide you in what codes they want to have used. I have worked in a clinic where they said, these are the codes we want you to charge, these are the combinations we want you to do them in, which, kind of made it easy. You didn't have to figure it out. But you have to, in most settings, you have to figure out what you're going to do. So you want to also make sure you're billing for the amount of time that you spent with the patient. So if you're spending an hour with the patient, you should be billing for 4 units of care. You should be figuring out how you're going to give them 4 units of treatment. So there are also variations, and we'll talk about the 8-minute rule in a minute. There are variations in coding. So here's an example. You're going to show a patient how to perform an oblique abdominal sit-up. So right away you think, oh, it's 97110, therapeutic exercise. If you're teaching the patient the exercise for the purpose of increasing strength and flexibility, 97110 on the nose. That's what you want to do. However, if you're showing the patient the exercise for the purpose of facilitating dissociative movement between the lumbar and thoracic segments to improve proprioception, you can bill 97112, neuromuscular reeducation. So a lot of times, I work with a lot of Parkinson's patients, and they have axial rigidity is one of the things you see a lot. And so a lot of times we are trying to facilitate the dissociative movement between the lumbar and thoracic segments to make them able to do these more functional activities. And so a lot of times I am billing 97112. If you're showing the patient the oblique crunch exercise for the purpose of improving functional performance getting out of bed, you can bill 97530, therapeutic activities. So there are a variety of ways you can bill for this one exercise, this one procedure, depending on your intent, and there's a proper CPT code to use, depending on your intent. You have to make sure, though, that you justify your treatment intentions and document them properly in order to avoid problems later with reimbursement. Because the insurance biller, if you don't document it properly, they can come back and say, you weren't working on therapeutic activities, we're not going to pay you for this unless you document it properly. So the Medicare 8-minute rule and all of the other, all of the other insurance companies follow this 8-minute rule, following the ranges of minutes to determine how many units of timed codes may be billed for a therapy visit. So 1 unit is greater than or equal to 8 minutes to less than 23 minutes. So 8 to 22 minutes basically is 1 unit. 23 to 38 is 2 units. 37, excuse me. Once you get to 38, you're into 3 units. So 38 to 52 is 3 units. 53 to 68 is 4. 68 to 83 is 5. So you're rarely going to be billing over 4 or 5 units. And so the thing is, though, is how you split that up. When you're doing a time-based code, you have to provide direct treatment for at least 8 minutes in order to receive reimbursement from Medicare. So when you're calculating the number of billable units for a particular date of service, the insurance company adds up the total minutes of skilled one-on-one therapy, divides the total by 15. If there are 8 or more minutes left over, you can bill for 1 more unit. If there's 7 or fewer minutes remain, you can't bill for another unit. So it's sort of a weird thing. But the upshot is, if you say that you're scheduled with a patient for 45 minutes, you're not necessarily treating them for the whole 45 minutes. You might be treating them for 40 minutes and spending 5 minutes doing your charting. You can't bill for charting time. So in order to be efficient in your charting and to really manage your productivity, you have to manage the number of minutes you're spending for each patient. So if you say you have a 45-minute appointment scheduled and you go 35 minutes, you can only bill 2 units, and so you're really not managing your productivity too well. If the patient can only tolerate 35 minutes, well, maybe they need to be scheduled for a shorter appointment. But that's one of the things that you have to pay attention to. You want to make sure that you are providing the care that you need to provide within that amount of time, but you also want to make sure that you're not shorting the amount of therapy that you're billing for. So one manager that I had when I was the first time I was working in a SNF, she gave me some really good tips on how to keep my productivity well and everything. And I actually used to wear a stopwatch around my neck. And when I started doing something with someone, I would start the stopwatch, and when I stopped, I would stop the stopwatch, and I would write down those minutes. Because you want to capture everything that you do. You don't necessarily have to go to the range of a stopwatch, but actually that was super helpful for me for learning how to time my appointments, especially in that type of setting. And I get so involved with the patient that I could go over time really easily, or spend way too much time doing something, and then not bill for it later on. So for me, it was really helpful for learning my timing using that stopwatch. After a little while, I didn't need to use a stopwatch because I got used to it. I learned how to do it. But it's super important you do want to be fully engaged with the patient. You don't want to be sitting there looking at your watch the whole time, but it's important that you manage your productivity. So references for this are the American Medical Association's CPT Codes. 2018 was the last edition that came out, and then every month they put out CPT changes, and the AMA manages that. So any changes that come up, they put those out monthly.